What's up, guys? Welcome to the PT Good podcast, where we talk all things ortho, from physical therapy to training. My name's Kane.
And my name's Mark.
So, Mark, what is on the agenda for today?
All right. What is on the agenda today is a continuation of our previous discussion in our previous episode about motor control. We discussed, what we think conceptually, what it is, really if it exists, how we implement it into our practice. And today we want to talk more about like how specifically we would implement these kind of interventions when it comes to different body regions, and just really like a more example based, like how it's integrated into our practice. So Kane, do you want to start us off? Give us a little bit of, just a recap on how you defined it. It's a summary of like kind of your interpretation of motor control.
Yeah, sure. So I think like the biggest thing for me is when I think about motor control is if I can create a change at the problematic joint by addressing something that is either upstream or downstream from that joint. So if it's elbow pain, for example, and it gets better by treating the person's wrist or the person's shoulder, that to me is probably a motor control issue. The other thing is if you change the sequencing of a pattern, or you just help a muscle be able to be recruited a little bit better, and that creates a change in their symptoms, I would also consider that to be a motor control deficit. Do you have anything that you want to add to that, or anything that you want to change?
No, I mean, I think our definitions are slightly different, but I think the way it, and then we'll talk about this more today, I think the way it fits into our practice is pretty similar. Like I discussed last time, to me, it's more so like, I'm not looking in some cases, I'm not necessarily looking for an observable change in movement. Sometimes I am, but I'm really looking for that symptomatic response. And, is it because, I guess, like I talked about last time, are we offloading a certain area? Is that just calming things down because they're moving differently? I don't know, but regardless, it's, implementation of or altering how someone performs a certain task to improve performance or reduce pain.
Yeah, I think that what you said about symptom modulation and going off of that, I think is super important, because like regardless of how you define it, you are still using the same baseline to help determine whether or not your intervention is effective. Mm-hmm. So I think that kind of just goes to show that even though we define it differently, that our patients are still responding similarly, as in they're either getting better, they're not getting better, they're staying the same, or they're getting worse. And we use that to help dictate where we need to go next, and if motor control is the issue at all. So I definitely find that to be a very strong guiding principle.
Yeah, and I want to reiterate too, like we use, test retest fits into this. We talked about this before when it comes to like directional preference exercise. Like this, you can apply the concept of test retest to multiple forms of interventions and treatment strategies, right? So, when it comes to how we implement motor control, maybe we've exhausted repeated movements. We don't really necessarily identify directional preference, but it doesn't mean that, it doesn't stop there when it comes to test retest. There's different ways we can begin to implement it. We'll talk more about today's specific examples when it comes to different body parts in terms of implementing what we will say, quote unquote, motor control exercises. And then just, from the last episode as well, Kane and I talked about motor control maybe having a bit of a bad reputation, but, we really want to emphasize that we're not saying people have to move a certain way. We're contextualizing it within the specific patient, specific individual, and within the task they need to perform or the pain that they're experiencing.
Yeah, for sure. All right. So you already mentioned or at least previewed a little bit, but we're going to talk a little bit more about the specific interventions for each of the body parts that we typically find motor control or these types of exercises to be the most effective on. So which body parts do you find that using exercises like these help the most?
For whatever reason, well, for me, I definitely bias towards lower extremity. So knee, hip, um, maybe foot. I feel like foot and ankle. I see. Um, yeah, well, let's just say probably knee and hip the most, and then foot, and then I don't do a ton of it for shoulder, but I feel like just from my experience, it seems like more clinicians I interact with will implement these kind of interventions for shoulder. But yeah, lower extremity in general, yeah, especially knee hip, come to mind. Do you find similar experience? How about you?
Yeah, I think we'll save foot and ankle for later on in this this episode. I think that's going to be a can of worms to unpack. But I do find that addressing knee pain and by treating the hip is super effective. I have had tremendous amounts of success, and I think it's so funny because when I was younger, so many people would tell me, like, when they were treating knee pain, I'd ask them what they're doing, and they would say, "Oh, I just load the quad. I just load the quad. They just need more strength." And I'm like, so what do you do if that doesn't work though?
Yeah.
And how often are you seeing that works? And I part of me wonders, like, what exactly is being addressed when they just like load the quad over and over again.
Well,
I don't.
I think this is a sneak peek into our next episode. This is something that comes to mind for an eval I had yesterday with maybe it's just exposure, but we'll save that for later. But I think that's the clinical presentation is different than what we're discussing today. But maybe in the case you're describing, like, they don't need the exposure. It warrants some kind of different intervention. But yeah, I wonder, to me, when people are like, I just got to load it, blah, blah, blah. To me, it's like, okay, you're just, an exposure type thing. But maybe it's not appropriate.
It's either that or it has to be like eccentric control that I think that's what I'm talking about. So I think that's interesting. But I mean, at the same time, I still think that if you're doing some eccentric control, that's still teaching our bodies like how we should be moving, even if you're loading just the quad, just teaching the person how to go through a motion slower. Because like Mark and I talked about this when we talked about doing sit to stands, right? Like the flop, oh my god, it drives me nuts. But if you teach a patient how to lower themselves slower, they're going to have to kick on their glutes better. They're going to have to actually learn how to eccentrically control with their quads, with all their lower extremity musculature. I think that's so important because like now you're actually getting things to fire, and then now they're reproducing this pattern day in and day out every time that they do it. So I think it's funny because people will use the term like, oh, we're loading the quad, we're doing this and that. At the same time, I think for the most part, and this is a bit of a preview for I think the next episode as well too, but at least in my head, I just don't find strength to be a primary deficit like ever, unless they are maybe post-op or something. But for the most part, like strength is not an issue. It is more or less like, are they good enough at coordinating their muscles to work together? Are they actually utilizing the right muscles to do said activity, or have they shifted it into their compensatory pattern and stuff like that? So that's where I'm like, okay, maybe it's just like how we're kind of viewing things and defining it.
Probably,
to me,
like if someone's limited in producing force because they have pain, I don't. It's not, I don't view that as a strength deficit. Yeah, right.
Yeah, like they have the strength. It's just being inhibited. Like you wouldn't want to do something that is painful.
Right. So exactly.
I think falling in line with what Mark said with the whole reconditioning thing and exposure to those patterns again is going to help desensitize.
Yeah.
And I think that's also important.
Yeah. Okay. So we're talking, we both said, hip, knee, lower extremity. Why don't you walk us through someone coming in? You can you lay the groundwork. Give us maybe like a little snapshot, maybe a recent patient you had that fit this category: knee pain, you addressed hip, and what are you looking for? What do the interventions look like?
All right, so this happens all the time. I'm sure most people can relate. Is general anterior knee pain or
Yeah.
like arthritic pain at times, even depending on the severity. And this could be both for the knee, or you could have like sometimes it works well for actual hip if it's like arthritic, or if they are younger and just haven't been as active. I find that this also helps a ton. Runners, for example, works phenomenally for, in my opinion. They could have like generalized hip pain, either lateral or like anterior running into their groin or something along the lines of that. The exercises that I will typically go to, I find that I love Captain Morgan's. I think that they're great. Some people call them hip burners, whatever you want to call them. I think that exercise is great because it.
Oh, is this on the wall
gets,
with the ball?
yeah, it's it's isometric with the with the ball, and then you're pushing yourself to try to go through the wall, and then you are marching. So I think the march is super important because now you're actually creating that isometric contraction, and now you're actually moving that joint in space, but it's offloaded.
Okay,
so
and you're working both sides, the stance side
when
and
you do
the
this.
yes.
Yeah, for sure. You're addressing both hips simultaneously, but for different purposes. I find that exercise to be super, super helpful. So especially if a patient is like really symptomatic, I'll probably start off there just because it's offloaded. If they end up not being super symptomatic or just progressing from that, I usually move them right into a lateral step down, because now you're actually loading the motion. And if I can create a change in how they are feeling when they do that, because a lot of times that step down is their comparable sign.
Yeah.
And you give them the Captain Morgan, they're like, oh wow, I can actually do this. This isn't as painful as before. That definitely tells me a little bit more about what's going on.
Okay, so we've gone from like a isometric to a isotonic, eccentric-ish type thing. Okay. And now, are you applying that first intervention and then retesting immediately, or is this a progressive type thing?
No, most of the times I will retest right away.
Okay, yeah. And then you can use you can use that comparable sign as an intervention later, or maybe right away, or like how does that fit in? Will you use your retest movement as, like, let's say step down was painful. Okay, now it's not painful. Now we can use it as our intervention.
Oh yeah, for sure, for sure.
Okay,
like,
cool. Yep.
if you've pretty much made a change in their comparable sign, that is now a comparable sign as well as an intervention that you can use to see like where else we can make that change, right? So what I'll do is when I first test them, okay, we see where they're at. You give them the Captain Morgan, see where they're at. If there's any change, and it's fine if there isn't, like it's muscular in nature. So I wouldn't always expect there to be a significant change right off the bat. Sometimes they need to do another round. Sometimes they need more time, and that's totally fine, right? But once I check their step down, and then they're able to do it better or with decreased pain, I haven't changed anything about their sequencing yet. I just gave them an exercise and just see how it feels. Maybe they just need to warm up more and they'll be okay. Right. But the other thing that I'll do is if they're still having some pain with it, then I might try to create some changes in their pattern. If I have them sit back a little bit more, if I have them feel for their glute to see if that's kicking on better, I think that when we do that, then we can double check. Hey, how does it feel now? Is the pain in your knee better? Is it worse? Is it the same? And then after that, just go on from there.
Okay. Yep.
Thing is, if I'm noticing that I've corrected their sequencing and their pattern and it still stays the same, we're probably barking up the wrong tree. And I'm not going to just
Right.
hammer that again
Yeah.
and again and again. I'll probably just let them continue to move how they've been moving until I better identify the more appropriate impairment at
Yeah.
that point.
Yeah. So like you walked us through this example progression, or you have your intervention, you retest, okay, and then maybe you can use the previously painful baseline movement that you tested. It's not painful anymore. Use that as your intervention. There's ways to progress, and then what you just said there was, and then the third thing was that okay, maybe if it's still similarly painful, you can begin to change their sequencing or start to alter how they're moving to see if there's a response there. But I like how you wrapped up there and you said that if you've done all that and you're not getting the response, yet you're it's barking up the wrong tree. Okay, let's move on. So it's not like you're saying, you've made these changes, they still have the same pain. This ties back to what we said before, and I think we're both passionate about when it comes to movement and the way we communicate with patients. Like, I'm not going to tell someone we're not going to tell someone they have to move a specific way if we don't find it's going to benefit them, right? Which is essentially what you were saying there. Like, okay, I'm going to, lean forward a little bit more when you step up, do this, feel it in your glutes. Oh, actually, it hurts the same. It hurts more. Yeah, I mean, like I said, it doesn't fit for that person. We're not going to do it, which I think we've both seen, or online or in person, like people like, oh no, this is how you have to do it, even though it does this, you got to, right? It's just, yeah. But I like that progression that you laid out there.
What about for you? What are you typically doing for hips or knees?
Okay, so the first intervention, the Captain Morgan type thing. Listen, man, small brain here. I keep it simple. I just grab a band around the ankles, standing hip abduction, but it's in a small range, right? I'm upright, maybe slight bend in the stance leg, right? You have your isometric abduction there, and then you get maybe to like 10, 15, 20 degrees of abduction on the leg that's in the air. So you have an isometric on that side, a little bit of knee bend, right, just to maintain that control. And then you're kicking on the other side, which when you described that Captain Morgan exercise, I was like, okay, this is similarly to where I would start. Right.
Yeah, super similar.
Yeah, right. So like I'm just emphasizing, listen, it's okay. Stay upright. You can get a little bit of bend in your knee, just because typically if people have knee pain and want to address hip, it's when it's underloaded flexion. So I'm like, okay, let's poke into it a little bit, right? Yeah. So a standing hip abduction, like I said, I don't want them, at least for the purposes of this intervention, that I don't want them to lean. I don't want, let's start with an upright trunk. So it's slight bend in the knee. Don't have to kick too far out. I just want them to feel the sides of their hips working, and inevitably they will, right? So, yeah, that's where I'll start. If I want to make it more dynamic, right? Okay, let's add a little bit of, like I said, if the knee flexion was the painful thing, right? Or let's just say like the step up, because you were using that was the painful thing, right? The retest after, how's it feel, right? Okay. If I need to progress more, if I feel like I need to get into, let's say, they're painful at like 90 flexion, right? Okay, maybe I'll have them, instead of just that standing hip abduction, I'll progress it to making it a little bit more dynamic, a sidestep type thing, right? So here, bend your knees a little bit more, maintain this position. We're getting a little bit more glute work involved there. Retest after. So that's kind of the progression I go with. I think, and maybe as we discuss more examples, you'll see this, that when I'm applying the, quote unquote motor control type exercises, it is, there is some exposure component to it, but I'm looking for like specific carryover to the task they're doing, right? So like, I'm looking for the people should be able to, like, the patient should be able to notice a change with it, right? So like we said, the step up, maybe I just start, depending on irritability, maybe I start with that like second progression of the side step type thing right away. But if I'm just looking for a little bit of glute work, just get some input into retest after. Yeah, like it's similar to where you started. So standing hip abduction, you were like, it was an isometric type thing, but we're working both limbs at the same time. Yeah, if it's like really, really high irritability, okay, maybe I can unload them, bring them supine, band around the knees, hip abduction like that, or like a banded external rotation around the feet, supine, something like that. So yeah, I have options. I think like when I implement these exercises, I take the load aspect into component, and I certainly take the task specificity component into account. And then like you talked about like sequencing towards the end. I don't look at the sequencing too much unless nothing else is like responding and it's just like I'm like, okay, maybe we can try to I skipped over how you talked about like with the step up, maybe with the trunk angle stuff. I definitely go there, right, if that's not working. But I don't know if I do the last step as much. But I guess maybe I don't find I need to go there as much when it comes to like sequencing. Usually, if you can start to load the person a little bit, they feel certain muscles working, regardless if we have to make a physical change in how they move. Like usually, if people just start like using a certain area and they move a little bit, it helps. And if it doesn't, then we can alter temporarily how they're doing the task. Like the way I view it is offloading the irritated area, and then as it becomes less symptomatic, then we can gradually get back to how they were doing it, and then they can just kind of move however they feel like moving. But that's typically how my implementation goes.
Yeah, I think what you said there at the end is definitely a good point to bring up.
Mm-hmm.
Is that I think it's important to know when you should be addressing variables independently.
Yeah, perfect.
So we talked about like, okay, we loaded it, and now what changed? Okay, did we get a positive change or no? And then after that, if we further load it, does it still make a change? Yes or no?
Mm-hmm.
And then after that, like when we've seen that there's maybe a plateau or that we're not getting the changes that we want, that's usually when I would do something else. And that's where Mark said that's when I would usually go towards the sequencing if we see that it's necessary.
Yeah.
There are other times where I'm seeing something, I'm like, hey, I have a feeling that if I just give them a cue, this is going to fix a lot of their issues. And we may have already seen that we give them some loading exercises and boom, a lot of their pain's gone. And then after that, I give them a cue and then now all of it is gone. Right. So it's just knowing sometimes like things can be a lot more clear cut, and I feel like it has to do with your pattern recognition too. You just see things and you're like, okay, this got you like part of the way there. This is going to close it out. Awesome. I can kill two birds with one stone and resolve your case a whole lot faster. Others are a little bit more complex, maybe a little bit more irritable, more symptomatic. It's better to just take it a little bit slower. Make sure that you're addressing your variables one by one, and then you can really see how things are changing, and make sure that you're giving some of these interventions time, because I certainly don't expect all of these things to always work right away. Yeah. Sometimes it just takes like a couple of sessions, a couple of weeks, and then you'll start to see changes. If you abandon it too fast, you may not see that change just because you're a little bit too impatient.
Yeah, the variable thing's huge. Like, yeah, I mean, you and I just laid out how our sequence, like how we do things, and we're implementing things, I guess meticulously. No, it's just, a single variable at a time. If we change a bunch of things at once, we don't know where we're going, right? Maybe one thing is actually making it worse, but, something else makes it better. And then we're at, it's just a neutral response at that point, right? But we didn't know if we just did one thing that made it better, it would get better, right? So, yeah, I think there has to be a system. There has to be some kind of sequence that's followed.
I agree. All right, Mark, I have one more question about this.
Yeah.
So you said that you use side steps for hip musculature. Now, one of the things that I got pushback for, and I used to do this, my go-to sequence was always Captain Morgan, side steps, and then lateral step down. That is the exact sequence I would use every single time. And then
I think I know what you're going to ask. Let's hear it. Go ahead. Let me hear it.
One of my mentors was like, why do you use side steps? And I was like, it's gonna hit the glute med, right? And he's like, but they're in a flexed position. Are you hitting the glute med or are you hitting the TFL?
Yeah, and okay. I'm getting angry here. Ask the question, man. I'm ready. Hit me. Come on.
So do you, and the follow-up to that was
Yeah.
TFL is almost always overly recruited compared to the glute med. Are you
Yeah.
reinforcing a bad pattern or not when you do this?
Okay, so multiple layers here. What are we gonna do? Live our lives like in a neutral hip position, a neutral trunk position, right? I mean, like I talked about movement specificity. I mean, if you're using your hip and knee in a position that you need to use it in, standing up from a chair, sitting down, lunging, squatting, picking something up, right? You're using your hip abductors in a flex position, right? So, firstly, I'd argue, I mean, that muscle's going to get worked, right? Secondly, I would argue, I don't know what overworked means unless we're talking about like using a muscle to the point that you injure yourself. When it comes to, I don't believe that we have, we can generalize to a certain population that, or just generalize to a population that you have to use a certain muscle more than the other one. Like, I mean, that completely takes out you and I's concept of, or not concept, but the concept of contextualization, right? It's just, oh yeah, you need to use this small muscle more than this big muscle that goes on a different part of your leg, right? And then thirdly, how you can't detect these things unless we're using EMG and stuff like that. And I don't know that there's data to say that if you use your TFL more than your glute med, in a certain population, that you're more likely to have this kind of pain, right? I don't think it. I don't know that it exists, and I don't think people have to. Again, I don't believe people all have to move a certain way, right? So, from my perspective, there's just multiple layers of unreliability and quite frankly, like a absence of evidence that we have to use a certain muscle more than another one. So I'll take it at we said we take it on an individual component. I look at it as a specificity component when it comes to where people have pain. Typically, it's like loaded knee flexion, right? So I'm like, I want to work into that position, right? So we're working specific to the joint angle and specific to the task there. That muscle's got to get worked in that position. So we're going to work it there. Now, that's not to say that we can't work, we can't do glute work in an upright, the first intervention I said, standing hip abduction, we're upright, maybe slight knee flexion. Yeah, we can work it there and test, retest. But I think at some point, like I said, like you want to stand up, you want to try and pick something up from the ground, you want to go up and down stairs, you're using your hip, TFL's there, you're using your hip abductors in a flex hip position. It's got to work. But I think this not a misunderstanding, but I think it's slight, maybe it's almost like dogma or kind of like this kind of concept from like the 2000s. It's like, oh, glute med, TFL, bad, hip internal rotation, bad, right? But it's like I said, I don't know what a faulty pattern is. I don't know what overworking a muscle in relation to another one is, unless we're talking literally like like a load tolerance, like an overload thing. I think this is just like old PT traditional like thoughts that are more recently being challenged, and I think those kind of thoughts can be harmful. And I think that contextualization and individualization of the treatment is the most important thing. All right, I'm done. I'm gonna sit down now. I'm sweating.
So there are parts to that I do agree with, and then I do understand the perspective from the other side too, which is if you are trying to strengthen the glute med and you're hitting the TFL on top of it, is it going to take over and then have the movement not effectively train the deficit that we're looking to address? So that part I do understand.
Yeah, like I'll say this: like I had someone come to me a couple weeks ago, and they have knee pain and they have what I would say hip weakness, and they're like, I don't get it. Like I work on my hips a lot, and they're doing a sideline hip abduction, and they're in like 45 degrees of hip flexion. And then I bring them into like neutral or tiny bit of extension. They can't even lift their leg up. Yeah, to me, that's like a relevant addressable impairment, or quote unquote impairment, right? So yeah, I'm not saying I don't do this, right? But also the thing that this person wants to get back to is being able to do a split squat. So, this is a good example actually. She's got moderate to high irritability. she could maybe flex to like 30 degrees on when they're in the split squat position. We got to scale back a little bit. We can't just keep ramming into this right now. And they found benefit from doing the side lying hip abduction and getting back into the split squat. They just had more. So this person described it as stability, right? They felt more stable, right? Compared to, I guess if we're saying TFL, abduction, internal rotation with hip flexion. Okay. Yeah, I get it, right? But yeah, so that I'm not saying I ignore these things, but viewing every single person and saying that, you shouldn't, I mean, you use side steps as an example. You shouldn't do side steps because it's not functional pattern, stuff like that. Yeah, I don't know if it's there for every single person. I don't think generalizing it is beneficial for patients, but okay, go on. Dude, you asked me this question. You knew it was coming, man. You knew it was coming.
It's just very interesting to see the differences in perspectives. Like I understand Mark's perspective, and I understand the perspective from the person who raised this question to me. And I mean, to be honest, I don't use side shuffles or lateral steps anymore, just because I'm too lazy to put the band around their ankle.
It's the hardest part of the exercise.
Yeah, that's the primary reason why I don't do that.
I thought you were going to say you don't do it. I thought you said you don't do it because they have to flex at the hip to put it on.
Oh my God. No, that is not the case. So yeah, I think it's just an important concept just to bring up some food for thought. Because like not everything can be viewed in a vacuum. Not everything can just be like applied across the board. Instead, like what Mark and I almost always say is you should really be taking your patient on as an individual. Like you really need to make sure that it works for them. And that's where we talk about the context and the nuance. And I think that that's super important. All right. So we hammered hip and knee, and we talked about different interventions that we use for that. One of the other ones that I want to mention before we move on is I cannot stop prescribing my patients prone hip extension.
Okay.
It is like before I would give bridges, and now I've just realized like there aren't a lot of actual good glute max exercises. Like a lot of times
like isolation type stuff.
In a way, yeah, because like there just really aren't that many. And the thing is, most people, if they do a compound movement, they aren't utilizing their glutes super well. They need a lot of cueing for that. So like if you have someone who squats, you see that they just use all quad. Like you get all the anterior tibial translation, and you're just like that is, oh man, that is no glutes whatsoever. So it's one of the things that I've started moving towards, because I did bridges. I'm like, dude, everyone can do bridges. It's not hard.
Yeah.
And then so I started giving prone hip extension. I'm like, oh, these people are really struggling with this. And I'm like, this shouldn't be a hard movement, but they're definitely struggling. And then when I retest it, a lot of their deficits go away. I'm like, wow, maybe this is something that really needs to get hit a little bit more. So that's just another exercise that I've been toying with a little bit more with a lot of my patients, because I've just seen a lot more success with it. And it's caused me to reflect, because I was like, okay, I am never giving just standing hip abduction or prone hip extension. These are like basic table exercises. Why would I give them this? I can give them way more functional patterns. And lo and behold, the guy who has pretty much loaded people as a strength coach has regressed back to this, because it works. It's just simple. Yeah. And it works so well for a lot of our general population, just because it's targeting the actual issue that really needs to be hit. And that's just one of the things that I had that epiphany the other day, where I was like, maybe not everything needs to be hard. Not everything needs to look cool. Not everything needs to be like difficult in a way, but you just need to find the right tool for the solution. So I found that to be a very interesting add-on into my practice. But let's chat more about shoulders and
Okay.
elbows and
Yeah.
wrists. Like this is like a common topic, especially for people who have had like true lateral elbow pain or anything along the lines of that. Like, is it truly elbow? Is it their shoulder? Like, where is it coming from? So, or like someone who's got rotator cuff tendinopathy or shoulder impingement or whatever you want to call it, you know. What are some of the ways that you look to address these different conditions?
For elbow, you said?
For elbow, for shoulder, what are you really
Mm,
looking at for these things?
yeah. I don't okay.
I swear to God,
Um
Mark, if you say
s-
spine, I'm gonna lose my
no,
mind.
no, it wasn't. Um I think the primary example I can think of when it comes to I'm going to start shoulder and work my way down. I don't even know if I have good examples for like elbow or wrist, honestly. So I'm going to go to shoulder, but shoulder, especially if it's like a recurrent like dislocate or someone who, you know, subluxes shoulder, we can quote unquote instability type thing. This definitely a case where I get kind of more specific exercise wise. So again, I kind of go back to like a more mechanical perspective where um, external rotation, horizontal abduction is, maybe they're more susceptible to that like anterior to inferior type dislocation, right? So I'm looking to work into that position while recruiting their posterior cuff to provide that compression stability, right? Um, so examples I can think about. I mean, I go to like a 90-90 ER. I can start like external rotation at 0, 45, 90. Once I get to 90, I can add an overhead press with it, focus, and then I can add they can go in past if they're able to. They can go past their like full flexion and kind of retract their scap back while they're in flexion. So they're just basically working into that previously vulnerable, I don't know, dislocation zone, whatever you want to call it, right? So like that's my progression there, and then I'm a little bit I'm pretty specific about how I want them to work when they're rotating, so they're working the right muscles. Sometimes, especially when you start to increase the amount of like abduction they're in, when you add ER, their elbow dips down, they retract their scap a little bit more, and then we're not really getting as much of that posterior cuff. So I really try and focus and, provide any kind of tactile verbal cueing so that they're recruiting the posterior cuff more. And I'm still letting the shoulder move. I'm letting the shoulder blade do whatever it wants, right? But I'm looking for them to feel stable, to feel good in that position. And sometimes, like, I mean, you may have like a recurrent dislocator, and then you have them just do some, they can tolerate that control. Maybe I just have them do like a 10-second hold in that 90-90 ER, and they just get that, let's just call it quote unquote activation. And then after, they're like, oh, yeah, I don't have that. I feel like I can do it on my own. It's not as, I don't really feel that, like apprehension type thing after, I can move my arm better, right? So like that's an example of how I'd utilize it in shoulder. There's not too many other presentations where besides if they have like insane winging or something like that. There's not too many other shoulder presentations I can think of right now where I would like definitely that's my go-to type thing. I think you may have a little bit more input. What do you got?
Yeah. So I definitely take a bit of a different approach here. I think what Mark said is definitely helpful. I have a bad shoulder too. So one of the things that I found is if it's particularly achy, if I toss in a couple of isometrics
Yeah.
for ER, we're pretty good. It tends the pain tends to drop down pretty fast. So I think that is a good way to at least start to approach it. The other thing that I'll typically do, let's just use Mark's example for this next one, is I use more like proprioception based exercises. So you could start with open chain stuff. I don't like this exercise, but it's something that can be introduced early on if they're especially symptomatic. It's like dynamic stability, where you probably see the clinician just like batting the arm around
Yeah.
while the patient isn't supposed to move. I think it's usually done way too fast. Like they're not supposed to move. They need to be able to react.
You can't just
and you're just swatting their arm.
Yeah, it's similar. It's
okay.
like similar to if you're doing like perturbations just for like balance, right? You got to let them recover. You can't just keep hitting them.
Yes.
Like you're not training
Yes.
the recover to strategy. Yeah. Like give them a second or two.
Yeah, so I utilize that for hips and knees as well too, but for shoulder, I pretty much just put them in a push-up position, and usually one single arm, and just have them hold and see how they do.
Yeah. I mean, I definitely, sorry, I use that a ton too, just because I mean, again, I go back to mechanics for this. You know, you're getting the joint compression, you're going to get the appropriate, like you said, proprioceptive feedback from that compression. And that may even be you're getting that direct physical cue, like the patient is when they do that exercise. I think that may even be like a better starting point than like the open chain, like external rotation.
You have no
type
feedback.
Stuff, right? Yeah, exactly.
Yeah.
Yep.
So I definitely like that. And one of the things that I think is really important here is when you are in that closed chain position, you're not just hanging out on your joint. You're not just like letting your whole body sag when you're holding your
There's got to be some intention
up.
behind it, right?
Yeah.
So what do you tell them? Yeah.
So I usually just have them start to push themselves away.
Okay,
And just by doing that, and I'm not a big serratus anterior guy. Like I just don't think that that's the case for the most part. But what I'm looking for is a co-contraction. If you are creating simultaneous contractions around your shoulder, it's going to be more stable. You're going to feel better. You're going to get more feedback that way. It is a whole lot better than if you're literally just hanging out on your joint capsule. You know, like your shoulder's going to feel a lot better. I know I am guilty of this when I am just like bored and doom scrolling and I'm like resting on my sink counter or something like that, and I'm just fully leaning and I'm like, okay, this is starting to bother me. So when I think about how that affects me, that's what I usually do for my patients, where I'm like, okay, maybe let's do this instead, and this creates a different change. So that's one of the things that I'll do for like a shoulder instability. But one of the other things that I usually tend to look for is just like, okay, when they go to recruit their posterior cuff, are they actually getting some type of recruitment from the posterior aspect of their shoulder? I don't care if it's coming from their cuff or if it's coming from their rear delt or anything along the lines of that. I can't tell. Just the mere fact, if they are getting like a mind muscle connection to the general area of where their cuff is compared to their bicep tendon, I'm pretty happy. You know, I will take that. You can cue them to retract and slightly depress their shoulder blade. You can change their arm position, maybe have them bend less at their elbow. So what I found is, like, if you drop their hand to go below their belly button and you have them externally rotate that way, it just decreases the amount of tension, and they're able to keep most of their focus on their posterior cuff. It just changes how it's loaded. Similar to what Mark said, which was like changing the loading so that it's no longer as irritated, right? So most of the times people are going to come in with anterior shoulder pain, and that's what we're looking to mitigate. So that's one of the things that I do. The other thing that I'll do pretty frequently is a wall slide with a lift off and having them hold it. So like you use a towel, you have them push up against the wall, and that's not the hard part, but that's like just to get them up in that position. But then after that, having them lift off and holding that overhead position is going to help them better recruit their traps.
Which is like, I think you described it better than what I was describing. That's essentially what I have people do when they get the 90-90 external rotation, press overhead, and then it's the pull back. Yeah, it's essentially that.
I get what you're saying. So I always thought that this exercise was funny because everyone before was like, you can't use your upper traps. You don't want to train your upper traps, because if you do that, they're going to overcompensate, and people are already overcompensating with this. It's where people hold their stress and blah, 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 blah. And to me, I just never understood this, because if you train your traps like this, maybe they won't be weaker and they'll actually be able to tolerate the different positions that you put your
Yeah.
shoulder in. They'll be able to hold your shoulder in these static positions because they're always working.
Yeah. Yeah.
So if you give them the capability, they'll be able to withstand the demands. So I think that a lot of those
Yeah.
issues come because they're weaker, and not just because like they're overworked. Most of the times,
Yeah.
people are not overworking their traps. They're a very strong and resilient muscle.
You test upper
So
trap in a certain way.
I do not particularly test upper trap, but
Okay.
what I'll do is, if they are having pain with it, and or like general anterior shoulder pain, right? And I have them do that motion and it decreases their pain, that's probably telling me that a lot of it is going to be more of a control issue. So it's just like, okay, if I start to train that overhead position, if I have them do wall slides with that lift off, if I have them do overhead shrugs, for example, and a lot of their pain goes away, I'm like, oh, looks like we just addressed their upper trap and a lot of their issues went away. Awesome. But it's not something I really look to test, because I can't really break that if we're talking manual muscle testing or anything along the lines of that. But yeah, those are like the main things that I'll typically do. So it's like ER with scap assist, or like facilitation, to make sure that they're actually getting good mind muscle connection to their posterior aspect of their shoulder. If they feel in their bicep, probably going to move on. Probably going to have to change something, or cue them more appropriately, or I might have to just like change the positioning so that way they can get a better recruitment from what I'm looking for them to hit. And then after that, working on upper trap, because I feel like that just tends to get neglected a whole lot of times. Other than that, I think that there is some merit to looking at like, and this is a little bit more complex. This isn't going to apply to our Gen Pop as much, but for our tennis players, for example, these are the people. That's why I actually mentioned wrist in this as well too. Wrist and elbow. Is people who play tennis or who golf and they end up having elbow pain. It's important to look at the wrist as well as the shoulder to see how it's moving. I do not do like the D1, D2 patterns ever, really.
Are there people that do it?
Yes.
Okay.
Yes.
Wait.
Sure.
Like add like the whole thing, like the supination. I don't even know what it is. I mean, okay.
They'll do like an abbreviated version of it.
Interesting. We're gonna have one of them. We got to have that on, someone like that on as a guest, because I'm interested.
So that is not something I tend to do, but it is something that I will do for those athletes, because it follows in the pattern that they need to move. Like when you serve, you're going to go cross body, and same thing for when you do a backhand or something along the lines of that. They follow those same patterns. So it's kind of just making sure that your shoulder and your shoulder blade work together, and that everything in your upper extremity works as a cohesive unit. Now, the one thing I want to bring about, and I think it's a good topic of discussion, is scap setting, or like the Y's and T's. Like everyone says, okay, you're supposed to move your shoulder blade, keep it there, and then you move your arm without letting your shoulder blade move. I have my thoughts on this. And so, Mark, I'm going to throw the question at you. What is your take on having someone move? I don't want to say move, but almost like set and pin their shoulder blade in a position, and then moving their arm, and implications of it.
Good luck moving your arm if your shoulder blade's not moving, right? But I think this goes back to like the upper trap thing. I mean, I think like if people have, localized shoulder pain and end range shoulder flexion, we got, upper trap. I mean, we need the upward rotation. Maybe there's a deficit there, right? So I don't think so. How should I put it? The shoulder blade has to move with the shoulder, right? I don't do like direct shoulder blade work if there's not like a, like I said, said like winging earlier, stuff like that. But I think we got to let it move, man. Let it fly. Let it, it's got to rotate. It's got to, it's got to move with the shoulder. So I don't really like it's similar to the one example I can think about. People are doing like rows with a TheraBand. It's just kind of like, don't, pull it all the way back and down and stuff, which is like, I guess that's fine if you want to, work the like rhomboids and stuff and mid trap or whatever. But like, I don't know how that helps with shoulder pain from, I guess, like a motor control standpoint. But yeah,
I think it makes it worse.
Yeah, it's like it's not moving, right? I think we gotta, that's why like a lot of the shoulder stuff is that I want to get to like I want to work those muscles within the painful range, and that's typically like end range ish type movement. We got to get the control. We got to get the I guess we can say stability. We need the exposure, and we need to train those muscles in that position. So I don't really, setting the scap stuff I don't really do it. I don't know that I see much clinical benefit from it. Thanks for setting me up there. But what about you? Yeah, what you got? Let's hear it.
Yes. So Mark and I share at least somewhat of a similar view on this. I agree. I think that for the people who just pin the shoulder blade and won't let it move at all, and then they're like, okay, now reach overhead, and then they can get to like 45 degrees of flexion. I'm like, okay, so you can't move if your shoulder blade's not moving. So when I have my patients do their Ys and their Ts, I still have them do this. I still have them set their shoulder
initially.
Right? So when they initiate, absolutely. When they're starting, they are retracting and depressing. I don't cue them to like bring it all the way down. Maybe if they are struggling to get into that position, I cue them to maximally retract and depress just so that they understand what it should feel like. But for the most part, after that, it becomes, okay, lightly retract and depress just to get some more like posterior activation. And then once you go to move, you just let your shoulder blade move. Like it needs to upwardly rotate. It needs to tilt. It needs to do all these things, right? So if you train it out of that pattern, I think you're adding more issues. And to go off of Mark's point when he said doing the rows, and I've seen this happen time and time again, where they're like, okay, before you do your row, make sure that your shoulder blades are all the way back and down. Don't let them come forward. You're just doing an isometric for your shoulder blades, and you're just using your biceps and maybe your rear delt to complete the row. At that point, you're not even training the scap, which is the whole point of doing the exercise, which that just drives me nuts. I don't understand the rationale behind that. So I think that understanding that your shoulder blades are meant to move. They need to be mobile. PTs mobilize scaps all the time. Why are we not letting them move when we are loading them too? That's just something that I don't know. It just never really clicked in my head. No one really trains that way either. For people who are trying to get stronger, no one sets their shoulder blades when they're looking to overhead press. Like you do it to be stable in the beginning, but like you can't focus on that when you're trying to actually like move weight and like be strong. So that's just like, that never really clicked with me. But the one thing that I think is a good add-on for this is when we get our patients into those positions for like the Ys and Ts, for me at least, is I'm also looking to encourage like thoracic extension and some rotation too. You need thoracic mobility and scapular mobility to actually perform these motions. Like if you don't have adequate mobility, you're going to run into some issues. You're going to compensate. And I think that's where it becomes a problem. All right. So we talked hips and knees, shoulders, and / upper extremity. I think the next thing that we can talk about is a big motor control
spine. There,
it's spine. So core stability and deep neck flexor.
Dude, I gotta go to work in an hour, man. You're gonna get me all excited.
So what is your take on this? Like, what do you do this? Do you find it helpful? Do you isolate stuff? Like, what are you doing here?
Do you want to start? I mean, you want to start lumbar, cervical?
I mean, to me, I can kind of group it all together.
Okay, let's group it together. I don't. Okay. Let's group it. Yeah, let's group it. So I don't. don't teach like TA whatever transversus abdominis. I don't do it. I will do a pale off press every now and then, but I don't, I'm not palpating a multifidi. I'm not looking, I don't, palpate TA. I don't really think you can, I mean, I think the data's here with me. You don't think you can reliably detect like this kind of activation. Like if you look at, if you're thinking you're palpating, you're able to palpate a multifidus. Like, you're going through like at least like an inch deep of like soft tissue, muscle, adipose tissue. So it's like, but I will do. I don't ever do TA. The most I'll do, I'll be like, oh, just like, tighten your stomach when you do this exercise. But I'm not teaching that. I'm in no way like looking for some kind of detailed specific movement when they do it. And if I do that kind of like, motor control core, quote unquote core type exercise, whether it's like that or a pale off press, it's more of from a, just, okay, we're going to do this and see how you feel after with your comparable sign, test, retest, or I'm doing it as a exposure type thing. So yeah, I'm just like, again, like I think if you move and do certain things, like those muscles are going to work and turn on. If you're doing a pale off press and you're keeping the band straight in front of you or the cable right in front of you, like you're going to use your multifidi. You're not just going to like spin back towards where the resistance is anchored. So again, I'm aware that there's some evidence that, saying like when it comes to muscle sequencing and using this stuff, it's, maybe it's beneficial. I think from an evidence standpoint, it's, we don't have to dig deep into this, but regarding like methodology, stuff like that, like I don't know how reliable it is, like detecting these things. I don't know. Yeah, I think there's a lot to talk about in that regard. But when it comes down to it, yeah, I'm not implementing these things, looking for specific muscles to be activated, stuff like that. I don't know in the clinic if we're able to, reliably like detect these things. And furthermore, is there benefit to doing this? I don't know. So yeah, I guess to wrap up, or at least from my perspective, I don't do these kind of exercises. I definitely don't do TA, not because I just don't think it gives me benefit clinically. I'll do like, multifidus, pale off press type things, but not to specifically work that. I'm just doing it as like a movement exposure, maybe a test retest type thing. Yep.
Yeah, so I kind of fall into a similar position here, where I don't think that core stability is something that a whole lot of people genuinely need for their day-to-day tasks. If someone is struggling to move well, we fix that first, right? But I don't think that a lot of that is going to come down to like actual core stability. I think that is mostly just like re-educating them on like maybe improving some of their sequencing, like for their functional pattern. But for actual core stability, I don't find that to be necessary. At the very most, I teach them how to brace because they've never actually been taught how to brace. But I don't do direct TA work or anything like that for patients who have lumbar or low back pain for the most part, unless they are a non-responder and they actually just need more activation in their musculature. I am not looking to like cue them specifically for like, okay, turn off your obliques, turn off your rectus abdominis, make sure you're just getting your TA, make sure that when you are stepping, you're feeling your multif kick on and stuff like that. Like, that's just not something I do. I found that it tends to get very frustrating for patients as well.
I was just going there. I think it can be harmful. It's just something. Imagine like someone, a provider, you don't have this body awareness. I think a provider tells you, oh, you should be using this muscle and this muscle. You can't feel it. And then now you're walking around thinking your entire life you've been doing something wrong. That's why you have this pain. You can't feel your muscles working. You're probably never going to feel like it's like, what a disaster. Okay, I'm going to calm down. It's like malpractice to me. That's just like, you're just setting people up for failure. Anyway, good.
Yeah, I think it really reminds me of this. I forget where exactly I saw this, but this was like at least a decade, like
Yeah.
a decade or two ago that I saw this video. So that guy shows you how long I've been looking and learning
Deep in the
about
trenches,
stuff like
yeah.
this. So there was a personal trainer who was just making a skit about this, and he's like, "Oh man, you're gonna have so many issues. Like when you do a bird dog, that you have zero multif kicking on, and it's just like." Where does this come from? You know, like how are you reliably feeling this, training this? It's similar to like what Mark and I talked about previously. It's like you're creating issues for your patients that were not necessarily issues.
Yeah.
Like these things can exist and not have any ramifications because of it.
It doesn't have to be relevant.
I think that's yeah, it really doesn't. So I think if you just teach your patients how to move better, a lot of these things just kind of get fixed on their own.
Yeah.
And if it doesn't, that's maybe when you can consider addressing it. But for the most part, from what I've seen in Gen Pop, that is just not the case. Like you just don't really need to do that. Instead, I think taking the reconditioning approach is very, very helpful. Like if you want to get them moving and keep them moving, that's great. I think that's a good place. That's a good way to do it. And I've started to term this, thanks to Mark, like a recovery of their function. Are they able to use a lot of their muscles again to do their like normal day-to-day activities without flaring them up? Can we progress them from there? And if we can, awesome, they're able to do more and more and more. That is essentially increasing their activity tolerance and their function, and that to me is like the most important thing. I don't care if someone can activate a specific muscle. I care if they're able to do what they need to do in their day-to-day life.
Yeah.
So that's just not something I've ever really paid a whole lot of attention to. Now, the one thing that I do, there are two things that I want to talk about, and I think that we can wrap up for this episode. But you mentioned Pallof press. I think that Pallof press is good for Gen Pop. It is something that I pretty much vowed to never give to my athletes because it is such a basic motion. You are learning how to brace and move 15, maybe 25 pounds away from your body. That's it. You're literally training to be more rigid. Versus for athletes, when is an athlete ever really in a rigid position and not moving? Right. So the whole point of doing these things, if you want to take this route, is you're trying to generate more stability in motion. You're trying to generate dynamic stability.
Yeah. Wait. Hold up a second. What about Pallof press on an upside down Bosu ball while you're squatting and someone's hitting the band?
Dude.
That's it. I mean, I think I just changed your mind.
Oh my God, that is the most. Oh, that is something that you would see on social media for sure.
Dies of cringe, yeah.
So it's just like this idea that the spine can't move, right? Like that's something that drives me nuts. Like core stability in a nutshell is that, which is like, okay, you need to provide stability for your spine, but it's never really taught with a whole lot of spinal motion. It's taught with extremity motion, but not spinal motion.
Yeah, I mean, I've heard people say, oh, your spine, it's like a pool noodle. It's like really, it's floppy and wants to move, but you got to keep it still. It's like, no, I mean, the purpose of your spine, it's a structure that's meant to endure movement under load. Like, I mean,
walk without your spine moving.
Yeah, imagine like, what are we going to wear TLSO like all day, every day? Like, it's weird.
Like it's if you see someone who walks well, you'll notice that they go through bouts of extension, bouts of rotation. Like it has to happen. So to me, it's just kind of wild that we really have demonized like spinal loading and motion. This is coming from two people who utilize MDT practices too. So I think it's so funny. But that's one of those things where I'm like, please, like if you have like an athlete or someone who is like whether it's a recreational athlete, college, high school athlete, a pro athlete, it doesn't even matter. It's okay for them to move. You do not need to just train them to only be rigid. And I would say that causes more issues.
Yeah.
But, that was the thing I wanted to touch on. The next thing was what are your thoughts on deep neck flexor work? Do you do it? We know that it is an impairment for headaches or for people who have a cervical spine pain, you know? So like, are you addressing this deficit?
What do you think I'm going to say?
I think I already know.
Yeah, no, I don't do it. Also, listen, everyone, public service announcement. A chin tuck and cervical retraction, chin tuck being capital flexion, they're not the same thing, all right? Stop documenting them as such, okay? Anyway, yeah, I just don't do it. I don't know. I mean, to me, it's like, I don't have an answer. I don't do it. I don't know. Maybe I should do it more. I can't think of a clinical presentation for the cervical spine where, besides like, I don't really see this really at all. If they just had like a cervical spine, like a surgery, like I don't know, like an ACDF or like a fusion or something. Okay, maybe I would do that just to add stuff in, but from like a motor control, like, pain performance standpoint, like I don't do this exercise. Yeah. I don't have much more to say besides that. Yeah. I used to, like, starting off, I was like, oh yeah, I would do it in standing with shoulder stuff and like, just an isometric type thing. But no, I don't. I really haven't done it, and I don't see a reason to start doing it.
Yeah, I would definitely fall more under that camp. The only exceptions that I can really think about are if someone, usually it's like a female, like younger female,
okay,
who has headaches or who has like chronic neck pain because of like mobility, usually like excessive mobility. If they don't respond mechanically, or I should say like with repeated motions, then that's something that we may take a look at. And that to me is essentially the same thing as like treating a shoulder. Like you get their cuff going and then a lot of it starts to feel better. And sometimes they just need more muscular activation here. Your neck is the same as any other muscle group, I should say. It needs some loading at times, and holding your neck up all day is essentially an isometric. And if it's not able to tolerate that, then maybe you need to load it. But other than that, I just don't really see a need to focus on that if that is not their primary deficit. It could be a deficit, but is it contributing to their issue?
Now, if let's say you do implement that, and I want to tie this into like lumbar spine. If you do you're looking for like to work a certain muscle, like let's say, and with the deep neck flexor type exercise, are you palpating their neck? You trying to feel the you're trying to turn off the SCM and you're trying to use the dude, I don't even know what are these muscles called that flex in there?
Splenius capitis, I think is what it is.
Yeah, that's posteriorly, right? Anyway, are you feeling for these muscles? You trying to get them to work?
I am not, for the most part. So I think one of the main things that I'll do is if I were to do this.
All right, longest capitis, that's what it is. And longer, whatever. Yeah.
Close.
But
that shows how good our anatomy is.
Yeah, you looking, you feeling them, you trying to get in there?
For the most part, if I am teaching them just normal, as you called capital flexion, then I do want them to focus on just using their deep neck flexors and then not using their SCM, right? But after they've learned how to do that, after they can hold that for time and not have any issues, and I add in the head lift, that SCM is kicking on. There's nothing you can do about it. Right? Like the whole point is just that, okay, now can we start to recondition this? Can we start to get some of those muscles kicking on better and working in conjunction with the SCM? And I think a lot of that falls in the same like boat and presentation as like what we talked about for the hip or for the shoulder, right? Is like if it's not tolerating the load and you start to reintroduce that load to those muscles and they respond better, you kind of got one of your answers.
Yeah.
And I'm not saying that this is something I do regularly at all, but it's just something that it's like I use the same type of decision making. And even though this isn't something that I default to or is in my regular toolbox, it's still there. If I use it once a year, I still know how to use it and know what to look for. I think that's the big thing that I wanted to get across is just like, are you able to still make the same decisions here based on those the contextual factors that you would be able to do so for like their hip or their shoulder? And just based on this discussion, we can see that they really do work similarly. We just need to make sure that that's how they're responding.
Yeah.
And I think Mark and I both fall under the boat of we do repeated motions first. And if that resolves it, awesome. And if it doesn't, then we go to other stuff. And this is just one of those other tools that you can certainly utilize. It's just not the first tool that I pick up. Like Mark and I have said, it is one of those tools that I feel like I don't know, I use maybe once a year, 2 years, somewhere around there. So it's very infrequent.
Yeah, like we're not neither you nor I are ignorant to the presentations where we could utilize it. It's just I mean, what percent of like cervical patients that go to an orthopedic PT clinic you think get DNF? What percent of lumbar patients you think are getting TA? Like for lumbar, I would say maybe like 90% plus. Yeah. And cervical, I don't know, 75, something like that. But it's just like, and it's fine. It's okay. I just think, maybe there's a more efficient, more effective way to get to the answer. Maybe, this thing doesn't have to, this specific intervention doesn't have to be applied to like, generally to patients unless it like really fits. And perhaps the strategies that clinicians are using to identify the appropriateness or identify the effectiveness of such an intervention really isn't as reliable as we think it is.
Yeah, and I think that like for the most part, I think that strength is almost always like a good thing to have, right? Like I'm not afraid to load my patients. I just don't see why this is necessary a lot of times for a lot of our patients. Sometimes like for Gen Pop, I'm just like, yeah, that's not needed. But if my patient was a football player or if they participate in combat sports or something like that, I am for sure loading their neck. Like that's their sport. They need to be able to absorb impact. And like that is a requirement. So I want to make sure that they are able to adapt for their requirements of their sport. So that's where I think loading is more than appropriate, right? But it's not something I need to use for everyone. And maybe the loading varies depending on the patient and whatever they respond to. Like I said, if they're a non-responder, then for sure, like I'll give that a try and see how it works. But if they abolish with repeated motions, why do I need to continue going down that route when we don't know whether or not it's going to help or not help, or if it's a deficit that's relevant or not? All right, Mark. We've gone on for a little bit about motor control and specifics about it. Is there anything else, any other pressing issue you want to talk about? I think we could go on for another few hours about this, to be honest with you.
Oh, easily. I mean, I think we got our main points across, being that, we started a little bit carryover from the last episode. Not everyone has to move the same way. We want to take the individual where they're at. We want to contextualize their symptoms, and then we want to find a way to address those symptoms. It's not, people aren't coming in and we're telling them exactly, hey, you should squat this way, you should sit down this way, you should pick things up this way, you should move your arm overhead this way. It all depends on the patient presentation. We're utilizing test retest, and then we have, you and I both described examples of the sequences of interventions we would use for let's say shoulder, knee pain, how we adjust the hip, things like that. And we spoke about, when we utilize these interventions, when it's appropriate, and that maybe certain interventions that are widely used by physical therapists, even though, maybe it's not, I guess in certain cases they could cause harm. But, maybe it's not the most appropriate thing to use. Maybe there's a different way, a better way to approach these presentations. But yeah, anything else you want to touch on? Anything you want to add to the summary? anything you think people should, take home message?
I think the take home message is to check out your variables, make sure that the thing that you are addressing is actually affecting your patient's symptoms. And then also just giving it time. Like these things don't just always resolve the issue within one session or one rep of it. So just make sure that you're giving your patient some time to adapt. Like that, I think that is a huge component to this, and it's something that Mark talks about all the time, which is like making sure that they are adapting to the stimulus and making sure that it's creating a change. Like if we don't give them the appropriate time, they may not make that change, and we may just be falling a little bit short. Imagine that you gave it to them, you were impatient, and then you moved on too fast.
Yeah, and like we talked about variables and like implementing variables maybe like one at a time, or not implementing multiple at the same time. Time's a variable, right? Use it to your advantage. Use it to gain knowledge and information so you can appropriately treat your patient. All right. Well, that concludes today's episode of the PT Good Podcast. Remember to leave us a like, subscribe to us on whatever platform you're listening to us on. Follow us on Twitter at PT Good Podcast. We thank you for listening. We hope you enjoyed. We will see you on the next episode.
Miss Love you. Bye.